Hello everyone. Let's see about endodontic emergency. Introduction. The endodontic emergencies deals with pain and swelling. The main aim of endodontic emergency is to relieve pain and control any inflammation or infection. Endodontic emergencies can be divided into three main groups: before treatment, patient under treatment, post-endodontic treatment. In before treatment, there are pulpal pain, acute periapical abscess, cracked tooth syndrome. In pulpal pain, there are reversible pulpitis and irreversible pulpitis. Patient under treatment, recent restorative treatment, periodontal treatment, exposure of the pulp, fracture of the root or crown, pain as a result of instrumentation in acute apical periodontitis and phoenix abscess. Post-endodontic treatment are high restoration, root filling, and root fracture. Let's see briefly about before treatment. A detailed case history should be performed. The patient's complaint and medical history is very important. Previous dental history plays a major role which encounters recent treatment, periodontal treatment, any history of trauma to the teeth. History of pain should be elaborate with the questions of where, when, description of pain, aggravating factors, relieving factors, any associated symptoms like tenderness or swelling. Differential diagnosis should be considered such as myofascial pain dysfunction syndrome, neurological disorders like trigeminal neuralgia, vascular pain syndrome, and maxillary sinus disorders. Diagnostic aids can be used are periapical radiographs, electric pulp tester for testing pulpal responses, ice sticks, hot gutta-percha, cold spray and hot water for thermal responses, and periodontal probe. Under pulpal pain, irritation of pulp causes inflammation and the level of response will depend on the severity of the irritant. If the irritant is mild, a layer of reparative dentin may be formed as protection from further injury. If the irritation is severe with extensive cellular destruction, leads to pulp necrosis. Pharmacotherapy for endodontic pain management are non-narcotic analgesics under acetaminophen 325 to 1000 mg, NSAIDs, ibuprofen 200 to 800 mg, aspirin 325 to 1000 mg, diclofenac 50 to 100 mg, and others. Opioid analgesics are codeine 60 mg and tramadol 50 mg. Reversible pulpitis. In reversible pulpitis, the pain is of very short duration and does not linger after the stimulus has been removed. The tooth is non-tender to percussion. The pain may be difficult to localize. The tooth may give an exaggerated response to vitality tests. The radiographs present with a normal appearance and there is no apparent widening of the periodontal ligaments. Management. The treatment of reversible pulpitis follow: check the occlusion and remove non-working facets. Place a sedative dressing in a cavity after removal of deep caries. Apply a fluoride varnish or a dentin bonding resin to sensitive dentin and prescribe a desensitizing. Irreversible pulpitis. In irreversible pulpitis, there is often a history of spontaneous bouts of pain which may last from a few seconds up to severe hours when hot or cold fluids are applied. The pain elicited will be prolonged. In the later stages, heat will be more significant. Cold may relieve the pain. Pain may radiate initially, but once the periodontal ligament has involved, the patient will be able to locate the tooth. The tooth becomes tender to percussion once inflammation has spread to the periodontal ligament. A widened periodontal ligament may be seen on the radiographs in the later stages. Then gentle finger pressure will be more than sufficient to elicit a response. Management. The treatment for irreversible pulpitis is pulp extirpation followed by cleaning and preparation of the root canal system. Irrigation of the pulp chamber using a solution of sodium hypochlorite should be done. The pulp chamber and root canals are dried under dry sterile cotton pellets placed in the pulp chamber with a temporary filling to seal the access cavity. Paper points are used to dry the canals. A corticosteroids or antibiotic preparation with a zinc oxide eugenol temporary restoration will provide an Effective short-term dressing. Continuation of pain following pulp extirpation may be due to the temporary filling is high. Infected pulp tissue is present in the canal. Some of the canal contents have been extruded through the apex, overextension of the apex or perforation of the canal wall. An extra canal may be present which has not been cleaned. If the problem is not found to be occlusal, whatever the cause, the remedy is retreatment of the root canal treated tooth. The procedure is done under local anesthesia. Acute periapical abscess. It develops from an acute periapical periodontitis. The typical symptoms are pronounced soft tissue swelling and a tender tooth, extrusion of the tooth or mobile. Differential diagnosis is a lateral periodontal abscess. Management. The immediate task is to relieve pressure by establishing drainage. Use small round diamond burr. Explore apical foramen with very fine size of 0.8 or 10 file. If a soft swelling is present and intraorally, then it may be incised to establish drainage as well. The soft tissue swelling should be examined to see if it is fluctuant. Incise the swelling with number 11 or 15 scalpel blade or aspirate using a wide bore needle and disposable syringe. It may be possible to aspirate the abscess via root canal as well. And root canal treatment is carried out, calcium hydroxide dressing is done and antibiotics is prescribed like amoxicillin. Cracked tooth syndrome. The common finding is crazing of the enamel. The symptoms are similar to irreversible pulpitis. Pain on chewing, sensitivity to hot and cold foods, pain which is difficult to localize. Pain referred along to the areas served by the fifth cranial nerve, acute pulpal pain, alveolar abscess. Diagnosis can be difficult and much depends on the plane of the fracture line and its site on tooth. A fiber optic light is a useful aid as it is will often reveal the position of the fracture. If it is vertical fracture, the prognosis is poor. If the fracture line is horizontal, the prognosis may be better. Management. Reduction of occlusal contact, restoration or full occlusal coverage, immobilizing the segments. Let's move on to patient under treatment. Recent restorative treatment. If the pain is caused by recent restoration, it may be a result of high filling, micro leakage, micro exposure of the pulp, thermal or mechanical injury during cavity preparation, chemical irritation, and electrical effect. Periodontal treatment. During periodontal treatment, if the lateral canals are exposed, pain are elicited, leads to perioendol lesions. In exposure of the pulp. If the pulp is exposed during the procedure, decision to extirpate or carry out pulp capping or pulpotomy depends on the pulp is irreversibly damaged or not. Root or crown fractures. It can be avoided by protecting the tooth during the root canal treatment. If the fracture is in vertical plane, the prognosis is poor. In a multi-rooted teeth, section the teeth and remove one of the roots. Pain as a result of instrumentation. The two conditions that may require emergency treatment during a course of RCT are acute apical periodontitis and phoenix abscess. As a result of over-instrumentation, acute apical periodontitis may arise. Phoenix abscess relates to the sudden exacerbation of a previously symptomless periradicular lesion. It is thought to be due to an alteration of the internal environment of the root canal space during instrumentation, which activates the bacterial flora. Management. Treatment consists of irrigation, debridement of the root canal, establishing drainage. Endodontic flare-ups. An endodontic flare-up is an acute exacerbation of an asymptomatic pulp or periapical pathosis after the initiation or continuation of root canal treatment. Predisposing factors. Significant factors. Under significant factors, shaping errors which are over-instrumentation, incomplete or under-instrumentation, improper shaping techniques. Cleaning errors are irrigant extrusion. Pulpoperiapical status, retreatment cases, other factors are anxiety, preoperative history of pain. Mechanism of endodontic flare-ups. Microbial infection and periapical inflammation leads to local adaptation response and progression of disease. In local adaptation response, it is initiated of root canal treatment gives rise to introduction of irritants, microbial byproducts, irrigants, medicaments, altered tissue proteins, which leads to severe inflammatory response and endodontic flare-ups. The other mechanisms are changes in periapical tissue pressure. Studies have shown that in teeth, increased periapical pressure, excessive exudate creates pain by causing pressure on nerve endings. Microbial factors. Bacteria are main causative factor in the pulpal and periapical disease. Enzymes, endotoxin and other chemical produced by anaerobes may cause persistence of periapical lesion. Most commonly found anaerobes are Bacteroides melaninogenicus. Effects of chemical mediators. Chemical mediators can be in form of cell mediators, plasma mediators and in form of neutrophil products. Changes in cyclic nucleotides. Character and intensity of inflammatory and immune response is regulated by hormones and the mediators. Immunological response. In chronic pulpitis and periapical disease, presence of macrophages and lymphocytes indicates both cell-mediated and humoral response. And the last mechanism is psychological factors. Under psychological factors, anxiety, apprehension, fear, and previous history of dental experience appears to play an important role in flare-ups. Managements. Managements are anxiety reduction, behavioral intervention, occlusal reduction, pharmacological measures, antibiotics, NSAIDs, and long-acting local anesthesia. Post-endodontic treatment. Factors which contribute pain after sealing of the root canal system are high restoration, underfilling, root fracture. The occlusion must be checked for interferences to avoid an apical periodontitis or worse, a fractured tooth. Root filling should not be overfilled. Cause of pain are presence of infected material in the periapical region and inadequate debridement of the canal. Management. Treatment follows prescription of analgesics and if the pain is more severe and infection is present, antibiotics. An attempt at removal of root filling and re-preparation of the root canal, periradicular surgery and apectomy. The excessive lateral compaction of Gata-Pacha technique causes root fracture. These are the references. Thank you.